every thought you think has a biological effect on your body and mind. Everything, every thought, every emotion we have is having physiologic effects in our body. Every thought I think, every action I take has a physiologic response in my body. There's rapport with the person in front of you. Are they listening to you or not? There's not a molecular solution to
Yeah.
all problems. It can help a little bit. I think that's the real window for psychedelics is they allow that to happen more quickly and more from like sort of exposing what are the underlying things that are happening in your conscious mind or subconscious mind, then the faster we can sort of get at a way to move forward with it.
Welcome to the Two Curious MD podcast. I'm Dr. Ali Ahmed.
And I'm Dr. Soraya Rahman.
With the wisdom from holistic, alternative, and these conventional medicine, we are here to challenge the status quo.
We're curious about the connectivity and complexity between diverse fields of knowledge as they relate to consciousness, chronic illness, mental health, resilience, and beyond.
Learning more about the art and science of healing, or listening to stories of extraordinary healing. You're in the right place. Let's dive in.
I'm Dr. Soraya Rahman, joined as always by my partner in practice and curiosity, Dr. Alia Ahmed. Today, we're thrilled to be joined by Dr. Kelan Thomas. Kelan is a psychiatric pharmacist who has become one of the most vital voices in the field, helping us bridge the gap between complex psychopharmacology and the evolving landscape of psychedelic medicine. From demystifying drug-to-drug interactions to navigating the nuances of microdosing and the future of clinical safety, Kelan brings a grounded, rigorous, and deeply necessary perspective to his work. We just found out as well he is working into impresario mode as we speak. And so we are expecting to also have more productions that are in the musical realm and change culture while we're also changing neurobiology. Welcome, Kelan. It is such a pleasure to have you with us. Thank you so much for being here.
Thank you.
Yeah. And we have so many topics to cover just with that. I met Kelan Thomas, and he was UCSF, kind of our cohort, our platform that we had with the Psychedelic and Entheogen Academic Council. He is a PharmD and has an extensive knowledge, I would say, not just about ketamine, but all of the psychedelics treatments. And he's a professor and teaches at Touro University as well. So excited to have an academic, but also somebody who's got this creative arts as well and brings that perspective into this work. You are a leading voice in the lens of psychopharmacology and the research and understanding medication, the interaction, the role of the pharmacist, which is very vital, especially as we're talking about this course of treatment in psychedelic medicine, which often comes up but often ignored. The psychedelic renaissance, as we now hope to imagine, often driven by stories of transformation and healing. As a psychiatric pharmacist, what initially drew you to these compounds?
Would say it started as a precocious teenager reading Aldous Huxley and reading lots of essays between Humphrey Osmond and Aldous Huxley. And I didn't think, that could be a career. So I just kind of bounced between, I was always interested in psychopharmacology from undergrad level. There were only maybe 20 programs in the country that had any kind of pharmacology undergrad coursework. So I went to Duke and did chemistry and pharmacology there and realized that, yeah, this is something I wanted to pursue. And then I've gone back and forth between like basic science and clinical sciences throughout my career ever since. I just learned about pharmacy when I was there from someone in my lab. I was in Cynthia Kuhn's psychopharmacology lab at Duke doing research on dopamine differences in neurobiology and just realized that maybe PhD is not for me. Maybe I'd rather do something more clinical degree based. And ever since, between from Duke to UCSF to Michigan to USC, practicing in Singapore for a year, I've just gone back and forth between basic science and translational science is really always what I've wanted to do, is to live between both of those worlds.
Yeah. I feel like you're the right person to ask this question of because you've kind of seen the broad spectrum. When we talk about psychedelics, when we talk about ketamine, there's this idea of the classic psychedelics and the non-classical or compounds like MDMA and ketamine. Do you make a distinction between them
I mean,
from
from
as a
a
clinician, maybe? Mm.
so yeah, it's a good question. It's whether I'm wearing my sort of pharmacologist hat or my clinician hat. Yeah, there are differences, but if fundamentally most of them are eventually getting to the glutamate system. And so it's just sort of like, how are we having these second messenger systems triggered, in what timelines? And as Goldolin has taught me, there's different sort of windows based on the molecular pharmacology about how they open these windows and critical periods of relearning. And I think all of that is vital. And I really think that we need to constantly think about the therapeutic elements, the psychotherapy with the pharmacology. I think if we just go back to the paradigm of just pharmacology only, it's not going to be that much better. So I think we need to optimize both sides and bring these two ways of treatment together.
And I would say this becomes especially important now as there seems to be an emphasis on research, and also the pharmaceutical industry being involved in that realm, taking over kind of the aspect of a drug, of a molecule versus the experience or the experience.
Hmm.
Um, and also recognizing that safety and efficacy are just as vital. So how would that really occur in your mind, or how should it occur when we talk about, psilocybin coming online next year? Um, how should these psychedelic medicines be administered in a safe, supported way without taking away from the natural, nature-based effect and treatment?
Yeah, I think it creates a real opportunity, and that's really what my entire career is going to be dedicated to, figuring out how do we integrate traditional psychiatric prescribing into this new paradigm of more of an interventional approach with long-lasting effects, right? We've seen from the data at Hopkins, at Imperial College of London, that 1 or 2 doses, people are still doing quite well 12 months, 16 months, 18 months later. So that's really what all I'm trying to figure out is how to get those to integrate more carefully, cautiously for the optimization of people's well-being mentally.
Absolutely. And one of the things, like you just mentioned, as we bring those two worlds together, the prescribing and then the psychedelics, the interaction of the two. And there's lots of different precautions right now about using psilocybin with SSRIs.
Mhm,
Deprescribing antidepressants is also kind of on the rise. So,
mhm.
how do you see these two kind of streams kind of clashing or interacting?
Yeah, so when I did the CIS 2017 cohort, that was sort of my primary motivation. Was I heard a lot of people being like, "Isn't that dangerous? Oh, serotonin syndrome." I said, "Well, I've seen for 15 years of prescribing multiple serotonergic agents together. I've only found one case of serotonin syndrome, and my mentors at USC and other places had seen zero in their whole career." So the first thing I wanted to get out there was writing a review paper about the potential risks. And really, the risks come when you add monoamine oxidase inhibitors. So my concern is like SSRIs and ayahuasca. That's really like one of the only things that concerns me. Psilocybin, not concerned. MDMA, we actually have studies and trials that have shown there does not appear to be any risk with those. So it's really when you stop the metabolism of serotonin and then add serotonergic agents, that's when we get into trouble. But as you both know, it's pretty rare to see people on MAOIs these days. I might have seen one out of 1,000 plus people that I've worked with that was taking an MAOI. But it is something to be concerned about with ayahuasca because we know they have monoamine oxidase inhibition. And so how do we navigate that piece with ayahuasca is always fascinating to me. And I know there's retreats and centers that have combined the two safely, but I think they minimize the SSRI dosages prior to the sessions. And I think that's like a good way to sort of mitigate harms, because that's really, for me, from a pharmacologic standpoint, that's the biggest interaction I'm worried about.
So for our audience then, our audience is a mix kind of community of
Mhm.
patients, people who are just interested in psychedelic medicine, and clinicians and other providers. Give us an idea of what serotonin syndrome is and what is the harm.
Mhm.
And what you seem to be describing is a harm reduction model for treatment.
Mhm.
So, give us some more information about what that would look like and what's the safest way to approach this.
Yeah, so the most specific symptom on the Hunter criteria for serotonin toxicity is that and the only case that I've actually seen in my clinical practice at a hospital inpatient psychiatry was seeing like myoclonus at the ankles. That's a very good indicator of something is awry. You can also see exaggerated deep tendon reflexes. So if you just do the patellar check and you'll see like a +4 on deep tendon reflexes. Those will help you distinguish, is this serotonin toxicity or not? And it's pretty rare, but it's something that I'm concerned with because then if you get that level of hyperreflexia and myoclonus, you can start to have sort of organ damages, seizures possible. Um, so those are the things that I would say to look out for from like Hunter criteria of serotonin toxicity.
Yeah, absolutely. And these are some of the ways in which we're seeing how this relative risk, right? This risk when certain conditions come together. So knowing that it's ayahuasca versus psilocybin. And then now I want to challenge also on this idea of microdosing. People are microdosing psilocybin. And I know you talk about the heart valve and, how, and I'm really concerned about that as well. I don't think things that are labeled benign are necessarily always benign.
Mhm.
When we use the word, we kind of minimize,
Mhm.
and say that, oh, it's fine because it's microdosing, it's nothing, it doesn't. But I'm really worried about the receptors on the heart valve because, yeah, if you can explain some of that and what your concern is.
Yeah, it's funny because I put this out, I don't know, maybe 3 years ago, something. Now I'm seeing it on TikTok and social media of challenging my hypothesis around this. There's been a really excellent paper from colleagues that was just published within the past year that really looks systematically and gives you some nice charts and graphs about different receptor pharmacology, different compounds, and what between their binding affinity to the serotonin 2B receptor, which has been implicated in valvular fibroblast proliferation. So that was really how it came to my concern was, people, if you follow the protocols like every 3 days for a month and then take a month off, I think the risk is minimal. But then I kept hearing more and more people saying, no, I microdose every day for a year. And I'm like, well, that may not be safe. We don't know. We don't have any data and no one's looking for it. That's the other piece that people are like, well, wouldn't we have seen it? I go, how many people tell their doctors they're microdosing? How many doctors would know to even look for an echo or anything? So yeah, you feel things like palpitations, shortness of breath. And I've had some people reach out to me since I published those articles and said that they did experience some of those symptoms, but then they stopped and then the echoes weren't high quality. And so it's very hard. If you're not looking for something, you'll never find it. That's
Mhm.
what I've learned in science.
So true.
It's like
Yeah.
it's sort of a Swiss cheese. You go, well, we haven't seen it. I'm like, well, has anyone ever had a sudden
Look
cardiac
for it.
death? And you would have looked for that. No
Yeah.
one. They didn't
No
tell their
one.
family. They didn't tell their doctors, right?
Right.
So
Nobody
that
knows.
it's something that I'm concerned, and other labs that have better pharmacology credentials than me are also concerned.
Mhm.
And then people look at animal data and they go, oh, well, we gave it to a mouse for, a couple weeks. So it's probably fine. I'm like, yeah, we used to work in phase 1 first in human clinical CNS trials, and animal data toxicology doesn't always track to human toxicology. So those would be my
Absolutely.
words of caution for as we move forward.
Yeah, absolutely. And so we don't have data from 20, 30, 40 years of use constantly. And when we do get that cohort, it's too late.
Hmm.
And there's this other impact that's to do with ketamine as well, the physiologic long-term impacts of ketamine. Do you want to kind of bring that up? Because that's something that we are very aware of. We constantly monitor for and mitigate.
Yeah, one of my colleagues has done pretty good toxicology work around ketamine. And we've seen this in places like London and Hong Kong, where it became more of a party drug and people got into ketamine use disorders.
Yeah.
And it takes probably about a gram a day, seems to be the threshold for a long-term like bladder cystitis problem where you're just, people get into really serious problems. But I think all of the current, especially NIMH protocols, or even like 1 mg per kg IM a few days a week, I don't see that there's any sort of toxicology risk there. It really does seem to be the threshold of people trying to intake about a gram a day of ketamine on a daily basis that we start to see more of that. But that said, everyone's different, and maybe some people there's, a different risk profile. But I just think most of the paradigms of ketamine assisted therapy are very safe in terms of the regards to bladder.
Yeah. And I wonder about also just to kind of get a little bit more granular on the
Mhm.
pharmacology too, because it's more of an acidic drug.
Mm.
It's irritant to
Mhm.
the bladder lining,
Mhm.
right?
Mhm.
One of the practices that's happening when we do administer ketamine is giving that bolus of fluid. And I
Mm.
wonder if that already has some sort of protective element to it, you know?
I would imagine that does help mitigate risk for sure. Yeah, I
Yeah,
think
versus
that.
like when we give IM and somebody's
Mhm.
maybe, so
Mhm.
even thinking about it to that level of administration. But yeah, go.
No, I think any type of hydration, if you're not sort of stressed, people aren't, that's been the story with MDMA is that all the stories about, oh, the crash, the blue. I'm like, well, stay up all night, a couple days, see how you feel. You're not going to feel good. So I think hydration, being in a calm environment, mitigate so many of the risks of ketamine as a molecule. And it's, again, like we know so much more about ketamine than we know about LSD or psilocybin. It's dosed in every hospital in the country every single day for 50 plus years, 60 years, 70 years now. So,
Well, I often get asked by patients and even other providers about ketamine. You mentioned abuse, but we also talk about, is ketamine a drug of abuse? Is it a
mm,
physiological, does it lead to physiological, and I say physiological or even psychological dependence as a form of treatment? Um, what are your thoughts there?
I think if you keep it in the treatment context, I don't think so. I think it's low risk compared to many of the daily treatments that we see in psychiatry every day. When it becomes a risk is if it's like a constant pattern of use, right? If they have access to it daily, then much like almost anything, people can form any type of addictive behavior to literally almost anything, right? These days. So for me, I don't see it as like higher risk than any other psychiatric medication that we already utilize.
Yeah.
It's really just the context and the set and setting in which it's prescribed and utilized.
Well, Matthew Perry comes to mind.
Mm. Hmm.
His addiction in history and his high use
Hmm.
requirement, was that an addiction of some sort? What would
Yeah, no, I remember seeing that followed that story very closely. And when I read the stories about, oh, he like passed out in the hot tub, I was like, oh, he had to be injecting. There's no way you could insufflate enough drug to
Mhm.
make you like that. And then turns out that's true. His like a lot of the people named in the lawsuit were actually injecting him with multiple grams of ketamine all the time. And I guess the way I think about it is like how many fentanyl deaths per second are there versus ketamine sort of deaths. And it's incredibly rare. Like you really do have to actually inject ketamine to actually risk any serious toxicity. It's almost impossible to get it from any other route than direct
Yeah.
injections.
Yeah. If you've got a good liver that works, it's gonna
Mm-hmm.
keep cranking it and
Mm-hmm.
get rid of it for you.
Yep.
Very
Yep.
short acting.
Mm-hmm.
Beautiful. Um, all right, Alia, do you have
I do. And
yeah.
I wanted to step back and talk a little bit about what you mentioned earlier about psilocybin, LSD,
Mm-hmm.
the classical versus the non-classical
Mm-hmm.
psychedelics. Should they be treated equally or differentially because of the mode of action, being serotonergic, one being non-serotonergic?
Mm-hmm.
What makes them different and what makes them the same?
Yeah, so that's like one of the fundamental pharmacology questions that I often think about is because with ketamine, which is an NMDA antagonist, they're working on the same sort of neuron infrastructure in the cortex, medial prefrontal cortex. And so there are projections of serotonergic receptors into the glutamate systems. And so I think a lot of the basic science research that's being done is starting to tease out how those interplay. So when we look at sort of like brainstem serotonin neuron projections into cortical layers where we have a lot of 2A density with psilocin, LSD, DMT, then they project into the cortical layer 5 pyramidal neurons that have both expressions of NMDA, AMPA receptors that are the glutamate system, but then psilocin LSD are sort of also integrated into that and production of brain-derived neurotrophic factors. So I think there's interplay, and I think as we learn about the pharmacology of all these different molecules, there's different timelines, there's different sort of receptor binding, how long they last and project. And I think ketamine's sort of the most direct that we have right now. But as we look out to psilocin, LSD, ibogaine, we might have sort of longer and longer ways that these pathways are triggered through second messenger systems.
You just brought so beautifully together that graph from Goldolan's paper and
Mm-hmm.
lecture, and I quote that all the time, where you see the lengths of action of each molecule, and you see the critical period opening, and you just brought together why that works in that way is depending on where it's kind of interacting, you can trigger them for longer and longer periods. And with ketamine, that is 2 to 3 hour, I'd say, yeah, 45-minute to an hour and a half window,
Mm-hmm.
and you've got neuroplasticity for what, 48 to 72 hours. And
Yeah.
so this neuroplasticity in that targeted way, in those pathways that you talked about, because they have to do with depression, that's where they're going.
Mm-hmm.
Right? That's where that strengthening is happening. And what I guess what I want to ask is it a dearth of that compound there? Is it that we've just kind of found the right key to the right lock? Or is it teaching us something about depression and the underlying systems and how we get to that place of depression? What do you think these molecules are uncovering in that way, if that can be answered?
Yeah, I think like you said, it's interesting if you track the actual duration of the subjective experience of each molecule. It does seem to track exactly with Gould-Dolan, who I consider an absolute genius in our field. Hopefully she gets a Nobel Prize at some point.
Yeah.
Um, I think it does track with the subjective experience. And then my concern is if we're start to use molecules that aren't having that long subjective experience, like what are we losing there? Because it seems to very clearly show the longer the molecule can, change sort of default mode network function, loss of ego, insights, whatever the case may be for it. I think if we just look too closely at the molecular pharmacology, we're missing something about meaning making and how long people need to experience and sit with discomfort or whatever's coming up for them. And then how do we integrate that back into their sort of daily life practices and actually start to modify the behaviors that got people into a state of mental health
Yeah.
crisis that they're in. So I think it is very important to, notice that the timelines for how long the symptoms improve seem to be very directly related to the duration of the subjective experience for psychedelics, whether that's ketamine to
Absolutely.
ibogaine.
Yeah.
Mhm.
Which so goes against like the microdosing protocols, right? It's like
Mm-hmm.
there's two separate ideas. It works in a small dose too, and it
Mm-hmm.
works through a subjective experience, and it's so confusing. And ibogaine, I know people are microdosing for various reasons.
Sure.
I think I want to bring it together a little bit too, because ibogaine is the most powerful one. And we haven't yet, and I think this is fair to say, we haven't yet uncapped or totally revealed all the different use cases for these medicines. We're not even close.
Mm-hmm.
It's kind of like the GLP-1s. They
Mm-hmm.
got them, then they started figuring out all these other use cases.
Yeah.
And I wonder if we're going to see that with like traumatic brain injuries and, spinal cord injuries. I mean, what do you see, or what's kind of the signal in the research maybe?
Yeah, ibogaine to me, from a pharmacologic standpoint, is one of the most complicated molecules that
Mhm.
anyone like Hamilton Morris talks about this a lot. It's just such a unique
Yeah.
sort of chemical structure and the pharmacology of it, and we're just barely starting to understand it at this point. But then yeah, the whole microdosing phenomenon, it's just seems like cognitive dissonance to me when people are like, I've somehow hacked the system. And I'm like, you're using a Sandoz molecule from the 40s that no one really actually studied. So you're using a big pharma molecule, taking it every day with no data at all. So the LSD microdosing always, I just don't understand what people are thinking and why. And most of the data has shown that in any of the trials thus far, there is no benefit, really. There's no
Yeah.
efficacy. And from a harm reductionist approach, I just want people to be aware there could be risks with it that are very real. So I focus on that. But yeah, I mean, there has been indigenous use of peyote, for example, on a microdosing basis. Like there are people that have used that in that way. And interesting, mescaline does not have the serotonin 2B receptor affinity. So yeah, like ibogaine, we don't know. Again, I think we need to also think and learn more about indigenous traditional use and sort of integrate that into research protocols, because turns out people figured out a lot of stuff thousands of years ago that we don't recognize.
Oh my gosh, you just mentioned something, because that's a vision, right? That's the something to put our visioning to. So knowing what you know, and we've both been in, lots of research studies and clinical experiences and things like that, and recruited people for clinical trials. There's a certain way we do things. It's
Hmm.
like, oh, you want a clean data set. You want the
Hmm.
data set to be as homogeneous as possible. There's like a real reason to keep it clean and demographically kind of so you can draw population level, outcomes and insights. Here, we're talking about kind of on a personal level.
And let me add to that, it has to be randomized and
And all of that, right?
Hmm.
double-blinded, yeah.
And
Yep.
So
how do you even conceive of that with molecules which literally alter the consciousness of the subject taking them? You cannot blind it. So,
Yeah, it's a big challenge. I mean, my colleague and friend Bilal Zaghetti has written a lot of papers about this concept of, functional unblinding and how could you control for that. But yeah, it's very difficult. But even the funny thing is, like, we don't question it around SSRIs, even though there's
yeah.
clear psychotropic effects that people can detect from taking an SSRI. But now it's become this big deal for the FDA that they have to grapple with. This changes the way that we think about randomization, unblinding. But to me, it's really just, does it work or not? Like, what are the outcomes? Is it
Right.
doing what we hoped it did, and is it causing any harms? If not, just let it go.
Yeah.
We need
Being
all
a
Dr.
tools.
Emmett and I were talking today just about this. You want to bring that up, Alia?
Mhm.
We
Yeah.
were just talking about it.
Well, we were talking about, I think we were talking about the placebo and the nocebo effect.
Mhm.
And I think this is kind of what we're alluding to when we're
Mhm.
talking about giving a substance. And we do this with SSRIs. Hey, you're going to take this medicine and, it may help you with this. We're already kind of biasing that patient's experience. In addition to, I believe that the placebo effect is also an effect. It
Mhm.
also has a spiritual, emotional effect. And why aren't we looking at that as a source of, understanding
Absolutely.
what actually does happen at that cellular level that
Mhm.
involves this unknown placebo effect? And to the opposite end, the nocebo effect, which is what we're seeing with SSRIs.
Mhm.
We are seeing a nocebo effect, a negative effect. We're seeing all the side effects
Mhm.
of chronic use or overuse or underuse
Mhm.
or incorrect use. Tell us a little bit more about um, what your thoughts are on placebo and nocebo effect in psychedelic medicine.
Yeah, as I used to tell my clients in inpatient psychiatry settings when I was, give like medication education groups, I would say every thought you think has a biological effect on your body and mind. And so, like,
Mm,
nocebo, right? Everything, every thought, every emotion we have is having physiologic effects in our body, right? And so, I think that, yeah, the intention, and there's also been data showing the rapport with your prescribing clinician is more predictive of outcomes than whatever medication you took. So I think there's room for all of it, but that's sort of how I think about that, is like every thought I think, every action I take has a physiologic response in my body. And so, yeah, it makes sense to me that there's no SIBO effects. There's rapport with the person in front of you. Are they listening to you or not? Like, yeah, there's not a molecular solution to
Yeah.
all problems. It can help a little bit, just like if you, the other thing a lot of my colleagues would talk about SSRIs, like if you broke your ankle and you can't walk, like you have to just stabilize it, right? That's the way I think about antipsychotics, antidepressants. If you're in crisis in a hospital, you're not able to take in information. You're not really processing things. And so you need something to sort of hold that cast in place. And with SSRIs, does that mean you need it forever? I don't know. I don't each individual could be different, but certainly if you're in the hospital, you may need it for some time frame until all the other things, exercise, diet, nutrition, behavior can shift. And I think that's the real window for psychedelics, is they allow that to happen more quickly and more from like sort of exposing what are the underlying things that are happening in your conscious mind or subconscious mind, then the faster we can sort of get at a way to move forward with it. So that's the way people always think as a pharmacologist that I'm just believe all medication is the only way. It's the furthest thing. The more I've learned, the less I believe in that.
That's
True.
amazing. That's amazing because it brings us to our earlier conversation, Alia, where we were looking at, how do you represent what we're seeing in our patients as data?
Mm.
Right? How do we have the typical way of doing these trials and they're running, but what you just described, how do we measure that? How do we measure the aspect of what was it for that first intake to be a really thorough therapeutic intake where that's part of the model is that you get to be, I mean, I can talk about your healing center, Alia, is like a patient gets to be in a container over the course of 12 to 18 months,
Mhm.
which none of these trials are running that long, of being able to see the similar therapist, do different kinds of work, move from phase to phase, kind of see the up and down kind of happening because the object is to get the patient to where their outcome, what their particular outcome is. And that's not something that we can put into a clinical trial. So where do you see these models kind of maybe blending into each other a little bit or starting to kind of talk to each other?
Yeah, people are starting to use more mixed methods models where they look at qualitative outcomes more than quantitative. Because, yeah, to quantify everything, maybe that's not important. Like, we do need some level of quantitative data, but when you start to, I think qualitative measurements have gone a long way in psychedelic trials because it's the first time you have to think about, well, what's the person saying? What do they actually believe? What's their meaning to them? And so, yeah, a lot of my colleagues are working on more advanced qualitative methods. And you can look at the language they use, you can look at that, you can score it all, you could quantitate it all in various ways. But I think those methods are still sort of emerging to get the best practices of what's accurate, what actually predicts mental wellness. So yeah, those are definitely important elements that people have been working on.
Yeah.
What are we tracking qualitatively instead of just, what's the score on the MADRS or the PHQ-9?
Right. Because those
I,
are the surface elements, right?
yeah.
And psychedelics and this work we're doing get to the deeper elements of who am
Mm-hmm.
I and
Mm-hmm.
what's my purpose and
Mm-hmm.
meaning. And how, we haven't figured that out other than the
Well, we
mystical
have.
experience questionnaire,
Yeah.
which I love,
Mm-hmm.
which thank goodness, thank you, Roland Griffiths,
Mm-hmm.
Yeah.
because that gives us some grounding,
Mm-hmm. Yeah.
a
But let me
starting
let me
point.
just pause here because we actually did a clinical study at our center
Mm-hmm.
on 5 women around the same age in that perimenopausal kind of
Mm-hmm.
premenopausal state,
Mm-hmm.
coming in with comorbidities, which we could outline multiple GI, endocrine, cardiac, and all of the systems in
Mm-hmm.
in the patients we had. So they were kind of complex. They had treatment resistant depression. And they completed a group ketamine experience over 6 sessions. And we had their pre-assessments for their clinical scale. We tracked those scales over the course of their treatment. Um, and we were able to capture that data. What we also did, and this is where the skills of narrative medicine, I believe, come in what you described, is we were able to, document their language of their experience through the
Mhm.
course of those 6 sessions,
Mhm.
and what they said and how they felt and how they described their experiences, and how they were able to bring kind of the meaning making of that and document it, their words, their language,
Mhm.
and using qualitative assessment techniques, or able to code for the language. And what we were able to observe in compare that to the mystical experience questionnaire was that most of the patients had the language of either identity or reprocessing, re-experiencing kind of, and in a holistic way, their trauma. So their story, there's a theme for each person's experience based on what they described.
Mhm.
And also, by looking at the mystical experience questionnaire, we were able to say, well, ketamine seems to have this signature effect. It tends to, um, because it's an inward experience, they tend to disconnect from that sense of reality, right?
Mhm.
They feel connected to something else besides they're not really, they have that dissociative effect. So they kind
Mhm.
of disconnect from, and they are able to connect to something. There's this idea of them losing that sense of time,
Mhm.
right? Because there's
Mhm.
that dissociation.
Mhm.
And so it had this signature effect of all of the patients. They all categorically described this, uh, out of the five, right? Out of the 5 questions of the mystical experience questionnaire,
Mhm.
which I said, oh, that seems interesting. It seems to be ketamine thing. How would you describe the type of experiences that patients have, say, with psilocybin or
Mm.
LSD or ibogaine and ketamine, in that type of experience with the mystical experience in mind?
Yeah, I think
Yeah.
they can all get to the same place. It's a lot of it is just dose dependent, right? Like the point 0.5 mg per kg. Most people are not going to have any type of psychedelic experience from that. But if you get to 1 or 1.25 or 1.5 mg per kg of ketamine, then you will. And as I remember in my CS program hearing Stan Groff say, he's like, yeah, when I took a lot of ketamine, I was just like a boot on a person's like foot. And you don't often have that with classical psychedelics.
Yeah.
So it's very transpersonal. John Lilly got into thinking that he could talk to dolphins with DARPA funding and all this. So
Hmm.
I think they all get to the fundamental same place. It's just slightly different. It's like the way they activate receptors is a little bit different, and timelines and everything. But I think even just as someone, when you live in your normal state, quote unquote, of consciousness, anytime you can be like, whoa, there's something else. How's that possible? I think that in and of itself really gives people a lot of sort of freedom. They feel like their consciousness is more autonomous than they thought. But if you've never experienced that, it's hard to imagine or conceive that that's possible.
Yeah.
No, that's beautifully put. It almost gets to the idea, the spiritual idea that Alan Watts brought up, which was, when you get the message, hang up,
Hmm.
you know, and you just got to the message, which was the realization that something is beyond our frames
Hmm.
and that we can get out there and back in a safe manner, and that all these molecules take us there in different ways, and that experience has something to offer us, whether it's growth, whether it's perspective, whether it's change, whether it's a break from a stuck mind, a ruminative mind of a depression, um, right, or a trauma that's
Hmm.
just kind of recurring over and over again. And that's that break to freedom that comes. Let me like kind of maybe telescope out one more time and even ask you, now we're in 26 as we're starting to kind of land on this really beautiful, intricate, and very deep conversation. um, where are we in this quote unquote psychedelic renaissance? I think Alia and I are definitely more newbies to this renaissance, I would say, because we're coming at it from the medical field. We're getting into it kind of in the last maybe 5 to 7 years. I don't know about specifically about you, Alia, but and also kind of seeing like there's kind of like an ebb and flow. There's one step forward, two steps back. We've experienced that a couple of times, and just like the stigma of this, the big cultural change that needs to come for these to even become part of the conversation that a regular psychiatrist may have with you in the office. Although if you live in California, they're already having it, So it's like a different. We live in a little bubble here, right? But where do you see the kind of field going? I know you're deeply entrenched in the research, but I'm sure you have an understanding of the greater field itself. That might inform our listeners.
Yeah, so Terence McKenna's counterpoint to the Watts quote was, "I just keep getting too many messages. Can't hang up."
They keep coming.
So I'm probably more in the McKenna camp, and McKenna also said it's just going to keep getting weirder and weirder until we have to talk about how weird this is, the whole human experience, and as people start to interface with computers, and it's just, our brains are not built for the level of technology that's coming at us. Like, our hardware is not caught up to the wetware or the software. And it's going to be a very challenging next few years. But I think, and I visited your clinic, it's beautiful, and that we just need to ground people in physical reality and give them space to really connect with people in a one-to-one thing. I don't think, as you were saying with narrative medicine, I don't think Homo sapiens would have survived without storytelling. And, I read a lot and think a lot about my sort of druidic lineage, where they didn't even write things down. Like, you had to be one-to-one, spoken or sung or played music. And that's why the Romans slaughtered the druids so quickly, was because they could just erase and rewrite an entire thing. And we're seeing this play out. Like, we're still in the Roman Empire, unfortunately, in America. And so I think that these are the things that we need to connect with people locally in your community as much as you can, and be present and show up. That's how it took a couple hundred humans to survive anywhere on this globe for as many millennia as we've been alive.
Well stated. Oof. I feel that. Sometimes I feel that in the room when we're, doing all this transformational work. Number one, that it's even possible. Like, it's like an everyday miracle to get to do this work. It's like, what? The human mind can survive even this? We see some of the most treatment-resistant cases, the ones that have lived for years and years and years having zero hope, and they're coming to this, and we see them change, and you're seeing it in the trials. So it's just like, when I first entered this field, I was like, why is everybody else not talking about this and as excited about it as I am? Because I'm like, if you have this, why would you not run with it? Like, for me, it makes no sense that ketamine is in every single emergency room, every single OR, and the indication for suicidal ideation is not included. That's just malpractice at this level, at this point. So we've had this data for a while. So anyway, to see how systems might change. Any thoughts on that, Kelan Thomas?
I mean, the ER colleagues that I have will go to ketamine quite quickly when they're like, we're not sure what's going on, but let's just start there and see if it calms people down. Because, like you said, whether it's suicidality or substance use, whatever it may be, just give that window. That's a window to start, and then you figure out what's going on from there. So I think it should be much more widely prescribed, compared to haloperidol, Ativan, and diphenhydramine. Maybe ketamine. I've had ER docs anecdotally be like, they were combative. They had hit multiple nurses. We gave, just a regular dose. They laid down for an hour, and they're like, "Oh, wow, my bad." So it's like, we're just not
versus restraining,
restraints,
calling the, security,
exactly,
and
exactly.
just trying to. I mean, that's the trauma, is really that. The system itself isn't traumatizing, and I hear these stories every single day.
Me too.
And I do want to kind of. I've got so many questions, Kelan. It's just like, and one of my questions is, well, if psychedelics are in nature and
Mhm.
they
Mhm.
are,
Mhm.
um, and we should we be doing treatment psychedelic medicine facilitated, or is recreational okay too? And there's
Mhm.
some cultures that would microdose on this as a medicine,
Mhm. Mhm.
as something to help as we caffeine, chocolate, whatever you can think of all of those things that are in practice. What would be the benefit of just saying, recreational use versus qualified facilitated use in using
Mhm.
psychedelics?
Yeah, I mean, I think you can see a lot of cases of recreational use where there's no change, right? Or it maybe even enhances bad behaviors.
Mhm.
And I think it's really just all about the intention, the container, set and setting of all of this that can create and change the dynamics of benefit versus risk. Again, I'm not someone that's all like everything needs to be clinical medicine. No one should ever be allowed to use it. I gave the testimony at Oakland City Council that it should be decriminalized because what right do I have as a medical practitioner to control other people's consciousness? Like, that's something that I'm very averse to. I just want to provide resources or education so people understand what they might be getting into. And then, being in a hospital room versus out in nature, like you said, if these medicines were utilized in a natural context, I hope that we get there where retreat centers, well, yeah, sure, we have qualified people to reduce harm, but then we're in, the hills of Oregon, for example, or seeing trees in Oregon, and that there's that sort of back and forth. And we definitely need more connection to the land. I mean, I live on unceded Ohlone territory here in Oakland, and I've read a lot of books about tending the wild, and this concept of, whatever we think we have here was because our ancestors were very carefully looking at land use, taking every plant, every animal, everything in the environment, and symbiotically integrating with it. And that's a lot of what we've lost in our current sort of war state, constant state of war. It's not a healthy way to live. It's not sustainable. It'll never work. There's never an end. So the more we can get back in touch with nature, and, in Oakland, like Lake Merritt, you can still find the spores from the Dead era, the Grateful
Mm.
Dead era, playing in Oakland Coliseum. It's still there. People still tend that. People know a lot of species around the lake. And so the more we constantly look to natural settings, I think the more in tune we can become with systems and be more symbiotic.
You even brought up this really beautiful way of thinking about medicine that comes from the land,
Mhm.
is tended to with the land,
Mhm.
is a different perspective and an
Mhm.
energy to the medicine. And we always talk about this because every medicine kind of seems to have a signature.
Mhm.
Ketamine has its dissociation signature.
Mhm.
LSD brings with it its own signature of the
Mhm.
60s and cults and things like
Mhm.
that.
Mhm.
And then you just brought this beautifully where decriminalization, coming back to the land, is regenerative, not just for the land, but for the people. And that the
Mhm.
medicine that is then born there is of a different kind. Do you see that? Like, you've got your pharmacologist mind that looks at the molecule and says, well, the molecule is the same. There's an objectively the same molecule coming out of all these different strains of
Mhm.
psilocybin. But then there's people who say, well, when you have a different strain of psilocybin, that's called a different thing and it does a different way. There's Shakti and there's tidal wave and there's all these different
Mhm.
types, and people are now kind of even looking at the would you call it the spirit of the medicine,
Mhm.
Even the
or
land,
even the
Yeah.
land,
where
right?
it's
That it's
cultivated.
yeah, and that's how the indigenous look at this medicine, right? Is like,
Mhm.
so can you speak a little bit to that? Like, how, as a Western minded, material mind, can we kind of bring in those ideas as well?
Yeah, it's a very different epistemology of if you are sort of stuck in this scientific reductionism that it's just this, it's just that. We have to taxonomy, classify, and then you later they figure out, oh, it's all wrong. Actually, that's not the same strain of cannabis, or it's not the same
Right.
strain of this.
Bacteria.
Yeah,
We
exactly.
renamed them.
So this is constant. There's sort of a colonial instinct of classifying taxonomy that we always learn later is wrong, right? Like That's actually the history of science and from the Western
Mhm.
lens. And so I think we need to, yeah, start listening to other perspectives of there's, animism, there's a spirit to everything. Even what were fungi were rocks in the past, then became fungi. So it's like we don't know. We're the youngest species compared to the rest of the natural world, and the natural world doesn't need us. They'll figure it out. Like they don't need us as humans. We're late to the game, and we need to be better stewards of the land, really,
Mhm.
ultimately. So,
So
I
true.
think it's that I've noticed that ketamine, and I say this to patients, ketamine is just a molecule.
hmm
And you're going to get a medicine, we're going to dose it this way. But this medicine, as ketamine, has a unique effect on you when it's even given on that dose. And that dose, you could get the same dose on another day and it would do something completely different.
that's
So,
right.
and it's strange saying this as a physician because we're trained the opposite way. We're told, hey, you're supposed to take this medicine, it'll reduce your depression. Most patients, 80% of patients, reduction in symptoms, first course of treatment, and it should work on you the same way.
hmm
And it doesn't.
No.
And then you're like, huh? So was it the medicine or was it the person? But it's the interaction
hmm
of that molecule in that system
hmm
and the source of that and how it's making its contact with your thought, with your emotion, which we don't have the answer for. We don't know.
That to me is still like hard to explain to people. Like I could give you the same dose
hmm
and you're
Mhm.
going to have a different experience. Sometimes people ask me, did you give me more or less? And part of what I'm noticing is where their nervous system is based, when we start.
hmm
Maybe there's an aspect of that. And even as you go through the second and the third and the fourth session, there's a softening. They're becoming more used to it. And maybe they're allowing it more. But what is that concept of allowing the medicine and fighting the medicine? Can you explain that a little bit just from your perspective and what you've learned?
Yeah, I mean, seeing, people in various altered states, whether that's through psychosis in an inpatient setting or psychedelically induced, or I think our consciousness can shift all the time, based on so many factors in our environment. And it is a challenge because there's challenges. I wrote a paper, the California legislation was trying to set legal limits for every medicine. And I'm like, you can't, like, this is complete nonsense. Like, they'd be like, you can have 10 of this or 100 doses of that or this many grams of psilocybin. I go, that grams of psilocybin could be tenfold higher than you think or tenfold lower than you think.
Yeah.
And so to me, yeah, that's a really big challenge for informed consent for people in trials and things is we don't know like how this is going to affect you. And like you said, it could be different next week than it was the same dose the previous week. It's definitely, we have actually quantified the exact milligrams, but it's something that is just changing the way that your entire consciousness operates
Mm.
in a way that's always somewhat unpredictable, and it's very difficult to tell day by day how it works. And so it's, to me, that's, but again, it's the range of human experience, right? People have the big fallacy for me as someone that's practiced in psychiatry for this long is that there's some sort of quote unquote normal consciousness. I'm like, you have no idea how the person next to you is processing this world, and you don't have the same range of experiences or every sensory input, how you make sense of it. It's highly variable, more variable than we give it credit.
Yeah.
And so then when you add
So
molecules, it gets
so
complicated.
MDMA
That's beautiful.
didn't get to phase 3.
hmm hmm
FDA has guidelines, phase
hmm
1, phase 2, phase 3.
hmm
Are we ever going to be able to get anything approved with FDA?
Yeah, we will. Yeah, I think some of the challenges of having a sort of nonprofit entity enter this space as someone that's worked with phase one CNS global clinical trials, like
Right.
it is very serious business when you deal with regulatory. I don't think the FDA has a resistance overall. I think at any given time, the people on review committee have different perspectives. And so I think it will get there. I think this was just like they looked at the data and they said there are some things that we expect, I don't love it, but corporate entities have been in this game for 50, 60, 70 years, and they keep everything to perfection. Like I've been behind the scenes of phase one trials. The amount of data, the amount of people involved is staggering. So for me, it's not that surprising that just letting therapists collect data at their sites did not quite meet the level of approval. But now they've got the people that, solved the S-ketamine approval process involved. It's going to happen. It's
So
just might take a couple years.
let's branch
Got it.
to this.
Mhm.
Spravato and IV ketamine.
Mm,
What's the difference? What's the similarities? Does it work?
Yeah.
And why, and it's Spravato. It's
mhm,
pharmaceutical. I say it's a pharmaceutical product,
mhm.
all of that. And we have this ketamine, which is
Racemic ketamine.
the racemic
Yeah.
Mhm.
ketamine. And one works different or the same. What's their efficacy comparatively?
Yeah, so it's interesting because in Europe they've had esketamine approved for quite some time, and a lot of the groups that were giving oral esketamine and things, that's where we have a lot of our pharmacokinetics data. So there's differences in potency, whether you're measuring analgesia or subjective effects. So dialing that in is going to be a challenge. But I was just actually at a psychiatric conference virtually today where there is a group that's starting to investigate esketamine versus ketamine intranasal. And I was asking, well, what's the dose equivalence? How would you do that? And to me, esketamine is pretty variable. And when you even look at their own FDA labeling, like intrapatient variability, anytime you introduce, insufflation, or oral, there's variability in terms of absorption. So IV is going to be the most reliable, right? I can tell you the pharmacokinetics, it's going to be the same every time. Whereas with insufflation, you can even look at the esketamine Spravato data sets. You'll see this variability in terms of the percent absorptions. So it's just a challenge of dosing, and that's why I know you have my materials of trying to quantify and use bioequivalence data to show like what's the estimation of this route versus this route versus this route.
Mhm.
But it's all an estimation. Individually, there's still variability.
Yeah.
Yeah.
And one of the other questions I have is like neuroplasticity, right? If
Hmm.
our goal outcome is neuroplasticity and a change in the way these networks are going and firing, there could be a slow boat and then could be a slightly speedier boat.
Hmm.
You're going to get there, right?
Hmm.
It's just right now when we're trying to serve more people and make sure that we create these pipelines, right?
Hmm.
Thinking about where somebody fits and how quickly to get them through. We're
That's right.
talking about now, right? Even reducing the timelines for trauma treatment from like 3 years down to like 18 months or
Hmm.
something like that.
Hmm.
And so, yeah, esketamine is a very interesting kind of, because when it first started out, I was like, oh my gosh, they did this because they can't redo the trials on racemic ketamine
Yeah, it
because
was
it's
a
starting to
cash
become
grab.
generic.
It was a
It's
cash
already,
grab.
it was
It
a
was a
cash
cash
grab. Can we
grab.
say
Let's be
that? Now
real.
we're saying that. I
I
feel it's
gave that testimony in Oakland City Council because they're like, the biggest pushback we have approved medical ways. I go, it's $830 a dose when the
Yeah.
molecule costs $1 to
what?
produce.
Yeah.
So
Yeah.
to me, like I've always seen at studying at Duke, UCSF, like there's a lot of games that are just hyper capitalism that have nothing to do with anything evidence based
Good
or health
medicine.
outcome.
Mm.
Yeah. But and taking out that L enantiomer, what does that do? If we just talk about esketamine having
Mm.
one enantiomer versus IV ketamine having both the L and the S,
Hmm. Hmm.
mirror
Hmm.
enantiomers, taking that out, how does that affect the difference between the two?
Yeah, I mean, it does seem that like from subjective and analgesia data is slightly
Mhm.
more potent, but
Mhm.
who cares? Like, why, anything can be dosed properly if you just know what you're working with.
And then you
It really,
insufflate it, so then it's all crazy.
yeah, it never had anything to do with anything except for capitalist instincts. There was no reason, there's no medical or pharmacology benefit I could ever conceive of to isolate.
Does the L enantiomer have an effect as well, or the metabolites as such?
They
Yeah, so
tested both, right?
they've done some studies on R-ketamine. They were like, oh, maybe this is better. We don't
Mhm.
know. No, they're so similar
Yeah.
that it's really just about the dose, the intention, the setting. All those things to me are more
Mhm.
important than any especially when you're talking about enantiomers, they're so close. They're binding to the receptors. Like if I could, you could run these visual models of the exact protein residues. They're all binding in the pocket. They're so similar.
So it's
But
like basically putting a lot of attention on something which is kind of a qualitatively very minute difference,
I think so.
expanding it and finding a market in it, which is what.
Exactly. That's what
And
happened with Spravato, yes.
we
That's
recently
what-
started using Spravato because it's FDA approved for treatment-resistant depression. We have
Yep.
insurance.
Access is
And
the
a lot of
key.
people can access it only
and
through
access
that.
is key.
Mhm.
And I have been surprised by the like Simi said, how fast do you want to get there?
Mhm.
How effectively do you want to get there? IV ketamine, we know we have data.
Mhm.
We've done
Mhm.
thousands of sessions to date.
Mhm.
Spravato possibly could get there. It takes a little longer. Maybe it's variable in, how you take it in. And it's all up to you anyways, right? And I'm surprised to see, yes, we're actually having positive results. However,
Mhm.
it's set and setting
Mhm.
always.
Yep.
If the set and setting, if you're giving Spravato in a chair in a clinical setting and you're giving Spravato in a therapeutic supportive
Mhm.
way with
Mhm.
guidelines, with, a
Mhm.
soft touch
Mhm.
around their treatment, your result is going to be different, 100%.
Absolutely.
Yeah.
Right?
Yeah, from a pharmacologic perspective, the maximum dosage of Spravato approval is underdosing people.
Yes.
Statistically, I would say, because especially given absorption possibilities of like 10%, 20%, 30% lower than you
Right.
think that will get into plasma concentration.
Right.
I think it's unfortunate that was the way that it was approached to me, because I think we're sort of not even necessarily always hitting the 0.5 mg per kg IV that the NIMH established the basis for its approval on. So that's sort of my critiques around it. But
Yeah.
again, like you said, we live in the systems we live in, and people need access. They need coverage. Medicine has become, one of the biggest drains on the US economy. And it's not because it has to be. 33 other countries in the world figured it out, but it's just the system that we're living in. So I think every access point for every client you see needs to be available and considered. And I appreciate how much you've done in your clinic to allow every possibility for every client, because everyone's different.
It's not a clinic.
Yeah.
It's a healing
It's
center.
a healing. I agree with that. I've been there. I agree with it.
So we're going to do something fun now. We're going to do rapid fire.
Sure.
Okay.
So I have some questions here. And then we'll close with a question and so while you're thinking about these questions, I want you to think of a question subconsciously about what makes you curious about this work. Or you can ask us a curious question. Most misunderstood psychedelic.
Ibogaine.
Most overrated psychedelic.
LSD.
Most underappreciated psychedelic.
Psilocybin, I think.
Biggest psychedelic myth.
That they're safe no matter what.
One indication where the hype exceeds the evidence.
I mean, LSD for ADHD, I knew that would fail right off the bat, and it did. It failed spectacularly.
Why did you think it was going to fail? I
Microdosing
want to
for
ask you.
ADHD.
Yeah. Why did you think it was going to fail?
Because I think
Quick.
it's people who have a certain range of consciousness in the tech world in Silicon Valley that I live in, that anything out of just like hyper focus felt somehow productive, but that's a very small percentage of the US population. So I was like,
Makes sense.
LSD for ADHD microdosing does not going to work for that.
Know
at
your
all.
population. Makes sense. Absolutely.
So now questions around your pharmacology expertise. Most misunderstood receptor in psychopharmacology.
Serotonin 1A is still an unknown about how these psychedelics are intercepting with that serotonin 1A receptor.
Most common misconception among physicians about psychedelics.
That any serotonergic drug will have a risk of serotonin syndrome.
Oh, boy. And then do we need more efficacy data or more safety data?
Definitely more safety data.
And one technology that you think will transform psychiatry.
People studying humanities more than science.
What's
You
your
landed
favorite
it.
your
I love
favorite
it.
your favorite science book?
My favorite science book, probably is, I mean, APA textbook of psychopharmacology has been very helpful for me.
Cool. Love that it's a textbook. Your most influential mentor.
Probably, I would say, was Kathy Giacomini at UCSF when I thought about the idea of tracing pharmacogenetics from each lab was just looking at one receptor. And then she asked me to look at some of the Kaiser psychiatry data sets. And I go, molecules go through enzymes, transporters, receptors. And she's like, yeah, come to my lab and do that. So that was very influential for her to trust me with that. And now she's the dean of UCSF. So she's my most
Beautiful.
influential mentor.
Oh, I love that she's a woman.
Hmm. Yeah.
Coffee, tea, or neither?
Coffee.
Well, those are my questions. Now
Yeah.
for your turn. As you were thinking consciously, what did your subconscious mind come up with?
I mean, yeah, it made me a lot of these questions. It's all these moments, right, throughout your training or education that can be such a light switch. So I had those moments at Duke with Cynthia Kuhn, asked questions there, Kathy Giacomini, Vicky Ellingrod. I was the first in their labs from my pharmacy school, and now they're both deans at Michigan and UCSF respectively. But just being curious and listening to people around you, I have the same instinct with my own students. I'm like, if you have a question or you have an idea, let's talk about it. Let's figure out what you want to do. But what I'm concerned of is I see fewer and fewer people with questions.
Hmm.
People think they have the answers or they're just aren't curious anymore. I don't know. So I've had so few students that want to approach and ask curious questions, but that's the way I got to do my job, was having those questions with mentorship and people around me that were. And again, maybe it was rare then too. I don't know, but it just seems like the way that we've commodified education, it's become like people think they can just buy the education. And it's, as you know, learning is about
Yeah.
engagement and direct interaction with material and people.
Oh my gosh.
Well,
That's such a
then the question that comes, well, what
love
is
that.
it about not asking questions that's changed in our society? Why aren't we asking those questions?
Well, so I read, both Orwell and Huxley growing up.
Right.
And
Bring it back to the circle.
unfortunately, we have the worst of both their predictions, which is we have a top-down sort of surveillance mechanism, but we also have information overload to where people just like can't get through the amount of information coming at them per second. And yeah, I didn't predict that. I thought it would be more Huxleyan, but unfortunately, the world continues to get more Orwellian minute by
Orwellian.
minute.
Yeah.
Very cool. And this is why you need the humanities people to
Yeah,
understand.
read some other books, not just
Right?
science books.
To inform the science, we need the humanities to
Mhm.
understand, because that is such a beautiful kind of synopsis of, yeah, to be able to step out of your frames of reference, to think audaciously. You need permission, mentors to give you that permission, but also to be able to have enough curiosity
Yeah.
and have familiarity with different knowledge systems to
Mhm.
be like, wait a second, there's a little gap here.
Yeah.
Or has somebody put these things together?
Right.
And looking around going, no, nobody did. And there you go. Those were those breadcrumbs along the way. And that's how we get to these impossible solutions, or that's how we get to these intersections where we have such a beautiful conversation. I just have to say, today's conversation really brought in
Yeah.
so much like
And
into
and the
it.
childish wonder
you.
that the child is, the 4 or 5-year-old, who's a childish
Mhm.
wonder.
Mhm.
He's asking questions.
Mhm.
They're asking questions. They've got questions galore.
Mhm.
That's the question, is why does that change? How
That's
does
right.
that change? And I
That's
love that
culture.
you
Yeah, the
yeah,
systems
that
and
it's top down
environments
and
wanna
it's
put you
Mhm.
on train tracks, and then you go, "Wait,
There's
all you
one
need
way.
is food and shelter, actually. Like, everything
yeah.
else is made up. Someone else made it up."
It's so
And you
true.
can, you may or may not accept it. It's actually up to you. Your consciousness is your
Yeah.
own.
Yeah.
So to conscious sovereignty over your own
Mhm.
consciousness,
Mhm.
to learning and curiosity, and just such a wonderful example of also how we can get to the really interesting synthesis area, the place of synthesis of different knowledge systems, and really arrive at new pathways ahead. So thank you so much, Keelan, for bringing it all together today.
And our next episode, Kelan, we're going to talk about music.
Oh, great.
And
Well,
pharmacology.
like I said, I mean,
Music as pharmacology.
I get jobs and paid from my science, pharmacology, medical knowledge base, but I know more about music and art and literature than I know, but no one pays
Let's
me for
get
that.
you on for that.
Nobody
second
pays you
episode.
for that. Let's get you paid.
That's the second episode.
Yep, sounds good.
I love that. Thank you so much.
Keep an eye on your email. We'll be contacting you.
Sounds good.
Yeah.
Thank you for this
Music and
conversation.
Thank you.
Appreciate you so much. Keep up all the great work you do.
Thanks for joining us on the Two Curious ND podcast. We hope today's episode inspired you to ask new questions and explore fresh perspectives. We challenge you to ask us those unasked questions that you're curious about in your medical practice, condition, health, and wellness.
If you enjoyed the podcast, don't forget to subscribe, share it with somebody just as curious, and leave us a review. It helps us keep the curiosity alive. Post or comment with a question or curious inquiry that you have and seek to explore or learn with us. Stay curious, and we'll see you next time.